Critical Point presents liver function tests in ICU, understanding acquired liver injury and dysfunction secondary to critical illness. Note this video topic is not about acute fulminating liver failure or acute on chronic decompensation events of liver failure in patients with previously known hepatobiliary disease on admission to ICU. Rather, it's an overview of how to understand the acquired abnormalities in liver biomarkers that are commonly associated with critical illness and the implications of these abnormalities for nutrition support. There are multiple normal functions of the liver, including a cluster of metabolic, synthetic, excretory, detoxification or purification, and storage functions. During critical illness, however, the liver is frequently exposed to a hypoxic state, multiple toxins and drugs, and inflammation, which negatively impacts upon this organ, and can produce clinical features including coagulopathy, infectious risk, glycemic derangement, acute kidney injury, and in the worst situation, encephalopathy, indicating liver distress. Since the liver has these hundreds of functions, there is no single biochemical marker that comprehensively measures liver function in a critically ill patient. Rarely, a patient will develop true acute liver failure in the ICU, a life-threatening injury of acute onset and leading to significant liver functional loss with encephalopathic features. More commonly, however, more than 60% of ICU patients without a pre-existing hepatobiliary disease will have evidence of abnormal liver biochemistry. And these changes are associated with a more complex ICU course, a longer ICU stay, and higher mortality, which is why they are included in prognostication scores such as the SOFA. In fact, most abnormal liver test findings in ICU are only marginally abnormal and may be a reflection of the severity of illness or the stress response rather than true liver dysfunction. This makes identification of liver injury or dysfunction quite difficult in the ICU. The most common alterations in liver biochemistry levels encountered in clinical practice can be divided into two major subgroups. The hepatocellular predominant, seen as elevated liver enzymes. This includes hepatotoxic injury, which is caused by exposure to one of multiple drugs used in ICU or exposure to another non-infectious agent like contrast medium, and hepatic dysfunction, or the cholestatic predominant picture, which is seen as an abnormal synthetic or clearance function, such as raised bilirubin in the ICU. In the critically ill patient, there are two main problems affecting the liver as a result of critical illness. Even in patients with previously normal livers, critical illness disrupts normal liver function. The first that we will discuss is hypoxic liver injury. This form of liver injury typically occurs for one of three reasons: an inadequate oxygenation of the blood reaching the liver, a reduction in blood flow beyond the liver's intrinsic compensatory mechanisms, which are significant, or thirdly, poor oxygen carrying capacity, such as severe anemia. This kind of event results from typically one of these four disruptions: hypovolemic shock, septic shock, cardiogenic shock or cardiac failure, or global hypoxia. And it results in a cluster of events which cause disruption or alteration of the blood flow to the liver and within the liver. These include hypoxemia, a low hepatocellular oxygen uptake, congestion within the liver itself, poor perfusion or reperfusion injury within the liver. And this causes a type of stress because there is a mismatch between the metabolic demands of this organ and the actual hepatic blood flow achieved. The result is a reversible disturbance of hepatic cells, or in the alternative, full cell death or necrosis. The biochemical features of this type of liver injury are an early and rapid rise in lysis enzymes ALT and AST, up to 10 to 50 times the upper range of the reference value. And this is sometimes followed by a trailing rise in bilirubin or bile acids, usually at moderate levels of less than 5 times the upper reference range, and occasionally a patient might also develop jaundice. Note that raised liver enzymes are a marker of cell damage, not of liver dysfunction. And this clinical picture is also typical of hepatotoxic or drug-induced injury. It follows a similar pattern, but it can be distinguished by toxin exposure or drug exposure on clinical history. The second and perhaps most common of liver test abnormalities among critically ill patients is this predominantly cholestatic picture. It is often caused or associated with gram-negative sepsis, major surgical intervention, severe trauma with shock, exposure to medications, and the use of parenteral nutrition, especially early on in the ICU stay and using high doses of fats and carbohydrates. The effect is a cluster of inflammatory mechanisms which lead to a transient accumulation of bile acids and bilirubin either intrahepatically or with extrahepatic features. The result is an increased hepatic cell permeability due to the inflammatory state, which can cause a low-level enzyme leakage. So you can see raised liver enzymes in a predominantly cholestatic liver abnormality in the ICU. But the main features are functional defects in the synthesis of bile acid, the clearance of bile acids, and the transport both intrahepatically and extrahepatically. There also seems to be a loss of feedback inhibition of bile acid production, meaning that bile acid levels continue to increase. And the cholestasis may also be induced by inflammatory-driven microclotting abnormalities within the biliary system. Now, it is quite unusual to have a true biliary obstruction in ICU, although this obviously can happen. Rather, the cholestatic picture induced by critical illness is associated more with an altered bile acid transport, poor bile flow, and biliary sludging. So it's more of a functional abnormality or functional cholestasis. The biochemical picture in this scenario is a rise in bilirubin and bile acid levels, classically manifesting later in the sepsis course with multiple organ failure, but can also appear earlier in ICU course. And it's often combined with a low-level increase in alkaline phosphatase and GGT, maybe 2 or 3 times the reference range. So this poor bile flow that results from critical illness seems to be associated with a promotion of bacterial translocation and may actually prolong inflammation in critical illness through this mechanism, and may also be associated with a reduction in lipid and vitamin absorption because there's poor bile availability in the duodenum and the upper jejunum. There is evidence that this response to critical illness may be at least partly an adaptive response, that there is this escape transport of bilirubin and bile acids, which may actually be energy saving for the liver under stress. And secondly, there is evidence that bilirubin and bile acids themselves have antioxidant activity and cytoprotective effects that may be beneficial during an extreme inflammatory state. So in summary, this table indicates the typical liver impairments in critical illness. The cholestatic picture is extremely common. The hepatocellular injury picture with necrosis, in particularly the central lobe of the liver, is fairly common and is often associated with acute kidney injury, sometimes acute lung injury. What is rare is acute liver failure, full significant liver dysfunction with encephalopathic features and leading to additional organ failures such as raised intracranial pressure and multiple organ failures. Some of the main reasons for these liver impairments are with cholestatic picture, parenteral nutrition is one of the most common ones, sepsis, which can also induce hepatocellular injury, hypoxia or ischemia, which is commonly associated with hypoxic liver injury, and then drugs or toxin exposure, which actually can induce any kind of liver impairment in the critically ill. Let's consider the implications of liver injury or liver dysfunction in the ICU for nutrition support of the critically ill. The first point to make is that in general, the nutrition support approach and requirement calculation and particular nutrient mix should be appropriate for the overall clinical condition, including the underlying diagnosis and other reasons that the patient may have entered the ICU in the first place, such as, for example, trauma or sepsis. However, there are some particular points to be made about nutrition support in patients who have liver injury or dysfunction in the ICU. If we start with hypoxic liver injury, this type of liver injury can be associated with spontaneous hypoglycemic episodes, which also negatively affect outcomes in the critically ill. So it is important to avoid the fasting state and not to leave the patient without a source of glucose. These patients also tend to be highly prone to acute kidney injury, often requiring renal replacement therapy. So applicable guidelines in that situation should be applied. It's also not uncommon that these patients may develop high levels of ammonia. It's unproven whether there is a particular approach that can actually counter this in the critically ill patient with high levels of ammonia. However, it might be prudent to be cautious when using glutamine if patients do have high levels of accumulated ammonia, especially if they have concomitant renal failure, because it's difficult to convert the excess ammonia to urea and excrete it. When considering cholestatic dysfunction in the critically ill, the important points are to avoid excess parenteral nutrition, especially early on in the ICU stay and if a patient is otherwise well nourished, to avoid hypoglycemia and excessive glucose loads, to use nutrients in a way that modulates the inflammatory state, which can be beneficial, and then to favor enteral feeding. This is important because it stimulates extrahepatic bile flow, which may improve the cholestatic picture. And it also seems important that restoring the normal intrahepatic recirculation of bile acid and normal recirculation mechanics actually may improve bowel oxygenation and barrier integrity in the critically ill. Check out the website criticalpoint.co.za for useful clinical resources for your practice or to request a topic for a future video.